Good day, everyone. It's great to be part of the program. I'm going to congratulate the organizers for pulling together this first global summit on hepatitis. I was asked to speak about the role of case finding for hepatitis B and hepatitis C in our prevention efforts. And it has multiple roles. Case finding has a role in preventing transmission, primary prevention, a role in preventing disease and mortality, secondary prevention. It provides evidence for policy and planning, and it is the target of our public health surveillance and program evaluation efforts because it provides the data that helps guide that planning and practice. First of all, as has already been mentioned in this session, there are a number of interventions that do not require case finding when we think about hepatitis prevention comprehensively, with hepatitis B vaccination being a prime example. And there are others that are listed here for blood donor recruitment, universal infection control in healthcare settings, and others. However, interventions do benefit from case finding. As again has already been mentioned, a prime example is knowledge that a pregnant woman is infected with hepatitis B. You can then offer additional interventions that improve the prevention of mother-to-child transmission over and above the timely delivery of the birth dose, with a remarkable improvement in prevention with the addition of hepatitis B immune globulin, and then the addition, in some studies, of antiviral prophylaxis, particularly for women who have high viral loads. You can increase that prevention benefit even further based on the knowledge of that mother's hepatitis B status. For hepatitis C, now that we're in the new curative era for hepatitis C, models have shown that you can now direct those therapies to reduce prevalence and incidence. And there are other examples that are listed on this slide. Now, in the case of maternal testing for hepatitis B, we do that in the United States, and this is some data that we just published looking at our public health management of hepatitis B infected mothers and their infants, showing, number one, the high proportion of them that were born in other countries. That forms the basis of our testing guidelines more generally, but then the high proportion that receive a timely dose of hepatitis B vaccine and timely administration of hepatitis B immune globulin, resulting in a very low prevalence of HB-SAG among their newborns. For hepatitis C treatment as prevention, we're really still at the modeling stage, where multiple models have shown that the higher the rate of HCV treatment among injection drug users, the lower the force of infection, lowering prevalence, and lowering incidence over time, with the impact of that intervention being greatest for when the prevalence of HCV is the lowest among that network of users. What we now need is to move from the modeling phase into demonstration projects to really see, does that indeed happen, and what are the best strategies to make it happen? Now, turning to where case finding is particularly important is the prevention of morbidity and mortality by starting a cascade of services that begin with the detection of hepatitis B or hepatitis C in an individual, and then moving them through a care and treatment continuum where different services are provided, whether it be counseling so they can take protective behavior change on their own, or certain other interventions to reduce their risk of alcohol, receive a vaccination, or receive antiviral prophylaxis. Now, the benefits for hepatitis B and hepatitis C testing linked to care and treatment are considerable. Studies show that there's a 50 to 78% reduction in the risk of liver cancer for persons who are on a hepatitis B therapy for a sustained period of time, with the greatest benefit with the newer oral agents versus using interferon-based regimens. For hepatitis C, You get remarkable declines in the risk of all-cause mortality, a 75% reduction in liver cancer, 93% reduction in liver failure, 93% reduction in liver-related mortality. So you have considerable benefits from case finding, knowledge of infection, and referring people to recommended services. That said, regrettably, knowledge of infection among people living with hepatitis B and hepatitis C is low. This is just one example looking at hepatitis C, coming from some data that Heinrich Wiedemeyer put together several years ago, showing the low proportion of people who are aware of their status or who have received treatment in almost all countries that were included in this analysis. I then superimposed the data for the U.S., which is about 49% of people are aware of their status, and the prevalence of the people who have been treated is also low. So high benefit, low implementation of case finding for secondary prevention. And we can talk a lot about, and we certainly are very excited about, justifiably, about these new, relatively short-active, highly effective curative therapies for hepatitis C. But if we don't have testing, you don't get their full benefit. There are multiple models showing this. This is one from Sylvie Dubic-Brabant from France, looking at certain countries in Europe, showing that with improvements in therapy, noted in the white bar, you get some increase in a reduction in mortality. But if you improve testing and linking to care, you get a much bigger benefit, noted in the gray bar. So you have to have testing if you want to achieve that full benefit of new therapies for hepatitis C. How do we do that? Number one, planning. You have to bring together the data, the stakeholders, the proposed activities to really develop a concerted plan of action. This is an example of our plan in the United States. From that plan, you can then develop policies. In our case, we have a policy for testing for hepatitis B, primarily focused on people born in other countries that have a high prevalence, and for hepatitis C, for persons born during 1945 through 1965, people who have risk for transmission, such as injection drug use, and other risks. Both of those have been put to the test of cost effectiveness and have shown themselves to be cost effective for the U.S. healthcare system. Those policies are based on data. The great majority of people with chronic hepatitis B are persons born in other countries who have then migrated into the United States. For hepatitis C, we're battling two epidemics. We have an epidemic of HCV transmission among young persons who are injecting drugs, noted in that incidence line graph on your left. And then we have an epidemic of morbidity and mortality among a highly prevalent population infected decades ago and now aging into a period of their lives where they're at risk for HCV-related morbidity and mortality. So how do we go about implementing these case-finding measures? Number one is education for both the target population as well as the providers providing services for those populations. Awareness of hepatitis B is very low in the United States among both public and providers, and we strive to change that through using a multiple channels of information. We also strive to see how we can change the health system to more easily integrate these interventions. This is an example of the use of an electronic medical prompt in a medical record system at Beth Israel Deaconess Hospital in Boston, where when someone checked into the clinic with a birth year born between 1945 and 1965, that clinician was sent a message that that person needed to be tested for hepatitis C. And as you can see, you had a remarkable increase in testing after that prompt was put in place. So we went, as CDC, we went ahead and developed a standard electronic code that could be inserted into any medical record around the country, and the largest provider of electronic medical records in the country, known as Epic, has implemented this type of prompt in their system. We also have algorithms to help providers conduct the test. For current infection, which I believe is the real target of case finding, is detecting people who are currently infected. Now, for hepatitis B, it's a little more straightforward. We have one test, HBsAg. A little more problematic, at least in the algorithm in the United States, we require two tests. An antibody test, if positive, followed by a nucleic acid test, typically a PCR test. Our problem is that of the people found positive on the first test, only about half get that second test. So you have people walking around who think they're infected when they're not, and you have people walking around who should be in care and they're not. And so a single test for HCV would be preferable. So we look for those. One example of that is the HCV core antigen test, which is a serologic-based assay, which in our laboratory we find have high concordance with PCR testing down to about 3,000 viral copies of HCV. And this could be more readily available in laboratories that are more accustomed, familiar with running serologic tests rather than a molecular test, as is in the case for PCR. We also seek to gather data to understand, is our policy being implemented? This is one example where we've gotten data from one of the large commercial laboratories in the country, Quest Diagnostics, and they give us the information about the number of positive and negative tests for hepatitis C. And then we compared that to when CDC and a second rule-making body, the U.S. Preventive Services Task Force, recommended testing for persons born between 1945 and 1965, and we have observed a 41% increase in HCV testing since those recommendations were put out, many of those tests being done in primary care where people are more familiar with getting their routine medical care. So that's good information. We now want to know, is it reaching the right populations, or is everyone getting access to this test equally? But at least it gets us some data to see how well we're doing. We also realize that the knowledge of testing has very limited value, that it really needs to be a gateway into those other services that can really prevent morbidity and mortality as well as transmission. And so in our demonstration projects, we look at this continuum of care. And so I give you an example of our hepatitis B demonstration projects, which were done in communities of Asian Americans and African-born Americans, showing that about a 5.7% HBsAg positivity, about 90% of those people received their results, 85% were counseled about the importance of that test result, and 83% were referred for care, but disturbingly, only about less than half actually made that appointment. So at least you begin to identify where you need improvements. In this case, patient navigation and other interventions need to be brought to bear to improve that care cascade. So in summary, case finding does have a role in prevention of both transmission and disease. It does provide the information that informs public health surveillance. It provides the evidence for policy development and gives you the data to monitor your programs and improve them over time. But case finding is dependent upon testing. And if you're not testing, you're certainly not case finding, and you're not really having as successful prevention program as you could be. And right now, we face the challenge of that we have a number of very effective interventions that could be greatly enhanced or even require case finding, and that case finding is not happening. So we have to begin to look for strategies to improve case finding, and I've highlighted some of those: planning, education of the public and providers, health system change, delivery of testing services where people receive care, and always striving to simplify testing, care, and treatment so they can be made available in as many settings as possible. And if we do that, then we can be much more successful in bending this curve of mortality that we're facing in this illustration for hepatitis C. Because the more we can test and link to care, the more lives that can be saved through our public health prevention programs. Thank you very much.
It's open for discussion and comments.
This question is Indy Tashtarch from Anam Foundation in Mongolia. Question is for Dr. Ward. What do you think about population screening? I mean, in Mongolia, we are planning to screen the whole population. I mean, each and every Mongolian. That's the goal for hepatitis B and C. And can you elaborate a little bit more on your thoughts on this process and what kind of things that we should be thinking about, and then, in planning and then trying to execute this plan?
Well, number one, any testing strategy needs to be tailored for the local area, so should be guided by evidence. So you need to have a certain amount of information to effectively plan your program. And so in the case of Mongolia, where you have a high prevalence of B and C, it may be a very sound policy to have that as your policy. And so with that, I think I would be concerned about the quality of testing. So you want high quality tests to minimize the number of false positives. You want to have educated providers so that they're giving the correct information when someone is found to be positive. And then you want to have services available so that the benefits of testing outweigh any risk. And we've talked about stigma and other negative consequences of testing. Those always need to be considered in the context of the benefits. And so if the benefits are there where they are getting curative treatment and they're getting the other services, it can decrease the stigma. While your education programs are also doing that as well. I also think general or more demographic-based policies do not reinforce stigma. I think they decrease stigma because it looks like it's a population-wide problem, not a problem of certain groups that people, if they don't feel they belong to that group, tend not to care as much about that policy. So I think when the evidence is there, a population-based approach rather than a risk group approach is preferable.
I loved your talk, John, particularly around the my issues around the quality of testing for viral hepatitis. And I've worked in 3 countries. In Taiwan, there's repeat testing, so people are repeatedly testing and finding out that they're infected with chronic hepatitis B. That for me shows the fact that there's a gap in how people are provided with that diagnosis and how it is that they should respond. In Australia, I did a needs assessment, and most of the people that I spoke to hadn't given consent for testing, let alone been provided with any information upon being diagnosed. And so these people are just kind of going out without any understanding of how it is they should effectively respond to the infection. And in China, you've got the issue where you have people who are diagnosed and provided with their diagnosis within workplaces and within educational settings. So people are being provided with their diagnosis in non-systematic ways and in ways which can be quite damaging to people. And where teachers and human resources people are providing a health providing a health service without any of the kind of safety that is included within the provision of health services, such as confidentiality. So I just kind of want to reiterate, it's actually, test all you like, but make sure that that testing is effective and that it is systematic and that it is for the benefit of the person being tested rather than just a data collection exercise.
Good points. I agree.
Dr. Ward, regarding the HCV testing, you mentioned that the HCV antigen testing, it may actually replace the RNA testing. So do you think, especially when it comes to precision of the lateral flow test as an antigen test, do you think in the future this type of test, it will replace RNA testing? What's your opinion about this?
Yeah. Well, right now, there's not a core antigen test that's licensed in the United States for use. I put out the core antigen test as one example of where I think our field should be going, whereas trying to develop that one test. I would take a little issue with Dr. Colombo in that I think we do need a readily available one test for virologic detection. And in many circumstances, that's going to improve the quality of diagnosis, whether you're linking to do the other testing for staging a patient that was mentioned, or if you truly are in a pan-genotypic era for therapy, you can have a true test and cure program. So I think there's a lot more work that needs to be done on, obviously, on developing this new generation of tests, whether it be a point-of-care PCR or a core antigen test, or other strategies. Quickly, many of our laboratories in the U.S. have gone to a reflex test where the same specimen is used to test for antibody, and then if that's positive, it immediately goes into PCR rather than requiring a second blood draw. So there's multiple strategies, but I would like for us all hopefully agree that the focus of testing is to detect current infection, and let's strive to make that as simple as possible.